Welcome to the APAP podcast. I'm Corinne Young. I'm a nurse practitioner in pulmonary and sleep medicine, and also the president and founder of the Association of Pulmonary Advanced Practice Providers. I'm going to be your host today, and we are going to be talking about raising the bar for PAH treatment, treating too low risk. And we're going to talk about what that means. Joining me today is the most amazing Melissa Wilson. She has joined us in other podcasts talking about pulmonary hypertension. Pulmonary hypertension is her whole gig. And so if you have not joined us for any of those other podcasts, I highly recommend you listen to them. But Melissa, I'll let you introduce yourself again to our audience.
Well, thanks, Corinne, for once again having me here today to join you in this podcast. I love doing things with you. As you stated, my name is Melissa Wilson. I am a nurse practitioner at Avon Health Orlando. Been working in pulmonary hypertension for just shy of 20 years now. So to say it's my passion is probably an underestimation. So very excited to be here today. And the timing of this podcast couldn't be more perfect, as the Journal of Heart and Lung Transplant just published the consensus on risk assessment in PAH. So I was very happy to be part of that work. So this is great timing, and very excited to talk to you about risk assessment, which is my passion.
Excellent. And we're going to talk a lot about risk assessment and how that plays in getting our patients to this low risk profile, right?
That's right.
All right. Well, let's start with treating too low risk. What does that mean to you? What does that mean to the PAH community?
So treating to low risk is really about driving goal-directed therapy. Got to give a little bit of history. When we talk about risk assessment in PH, while our first risk calculator was developed somewhere around 2009, where we're looking at the REVEAL registry data, uptake for that was a little bit slow. Really, I would say in 2019 to 2018 really is when risk assessment truly began to blossom in PH. And it took away the concept of us looking at different variables that our patients present with: their hemodynamics, their echocardiogram, their 6-minute walk tests, their pro-BNPs, and trying to decide what matters the most to us as clinicians to say how well a patient is doing. But it also often left for us to look at things more in a retrospective perspective, right? Versus using the risk assessment calculators, what that allows us to do is take all those variables, maybe reduce some of the bias that you may get from a clinician, and now look at how that patient will do going forward in the future. So when we say we're treating to low risk, it's really a goal-directed therapy, so to speak, with the goal of driving that patient down to having the best possible mortality outcome. Patients who are low risk, when you look at year 1, you're looking at more than 95% of those patients being alive. When you look at year 5, you still have a very high, greater than 85% patient survivability with PAH. Versus when you look at those patients who are high risk, you specifically lose a lot of those patients in year 1, and by year 5, that mortality looks significantly more bleak. So by treating to goal risk, that means we are now to low risk. We are really looking at where our patients are currently and what can we do to modify or enhance their treatment plan to now get them to that point, versus kind of going, well, let me wait a little bit longer to see how you're doing. It's telling us right now, this patient is not optimal. They're not where they need to be. So let's look at titrating therapies, adding therapies, potentially even modifying therapies, and looking at what things we can modify about that patient to help get them to that low risk category.
So you mentioned risk stratification, and we see this a lot in the literature. We see this in some of the guideline recommendations to make sure we're risk stratifying patients. So could you talk to us about some of these tools that you could use for risk stratification? And, these have been validated tools, the majority of them, maybe even what tool you prefer to use in your practice?
Yeah, so there are several risk calculators. One that was kind of early on was the European Respiratory Society, European Society for Cardiology risk assessment. It really was like high risk, low risk. I'm not going to lie, I kind of liked it easy. It was black and white. Either you were there or you won't, or you weren't there. Then we had the REVEAL risk calculator, and that was based off of the largest registry done in the US. 3,515 patients were enrolled in this study. There's the original version, and then there's a 2.0 version. The 2.0 version truly, I think, became that much more specific in managing and helping us understand and manage these patients better. You also have the French registry as well as the Swedish registry that you can also utilize. The risk stratifications are now high risk, low risk, intermediate risk, intermediate high risk, and intermediate low risk, depending on them. We have long calculator versions and we have mini calculator versions. The more comprehensive ones, the ones I'm defining as long, are generally done at baseline. And each time you get a new catheterization, you really should use that full calculator. But in those in-between visits, usually about every 3 months, you would then use those so-called mini calculators or the light calculators to assess your patient. So you ask which calculator I like to use. I live in the US. So I believe in using a calculator that greatly reflects the patient and the populations that we have here compared to our European allies. Also, I like the Reveal Risk Calculator because it also includes things like hospitalization. So the variables are different among the calculators. There are a few things that are core to them. WHO functional class, 6-minute walk test, pro BNP, and WHO functional class are all part of all of them. But they do tend to get more granular. Some include CPET, some include, is there a pericardial fusion? So there's different variables. Also, there was a study that looked at the discernment between the calculators and found that the Reveal 2.0 tend to be more discernible than the other calculators as well. So that they're not exactly equal. So I do tend to use that Reveal calculator is our number one go-to in our practice.
I'm in a community-based practice, private practice. We treat a good amount of pulmonary hypertension patients. We don't do as many right heart caths repeatedly in our patients as I see being done in PH centers. I mean, they definitely get their baseline and then we repeat kind of based on which provider is seeing them. So it may not be very often. So I really like the light, the Reveal Light or 2.0 is a great one because you can utilize what's, their labs, their echo, their walk test, their heart rate at that visit, their blood pressure at that visit, and really get an understanding, are they low, intermediate, high? So I like that one too, because it's something you don't need a lot of data to perform.
Right. It's those non-invasive variables that are sitting in front of you at most every visit. So that's exactly why those are the perfect ones to use for those between visits. But if you get a new catheterization, that is a great time to get a fresh, new full calculation. Same thing like you said with the Reveal. Instead of getting the light, you do the full Reveal 2.0. And then for the next subsequent visit, you would go right back to using that light calculator.
Okay, staying on theme with the calculators. If you are looking at your patient's calculation, very first visit, you really haven't done very much with them. You know that they're high risk or intermediate risk. What is that telling you? And then when you repeat that calculator, what are you wanting to see? And if you don't see that, what are you doing?
So if I met a patient pretty early on, well, let's just say, because it may not be early on in their care continuum, right? And their disease progression, right? They may not be early at that point, but meet a patient who's high risk. That again tells me that I look at it as a lot of opportunity. That patient is sicker. Their long-term outcome is poor. It is suboptimal, right? And who doesn't want to live a longer, healthier life? So I look at it as a lot of opportunity. It gives us an opportunity, one, to follow those guidelines, which is those patients are still recommended to be on parenteral prostacyclin. So we know we need to start those patients on parenteral prostacyclin in addition to probably a combination, dual oral combination therapy in the background would be the appropriate thing for those patients right out the gate. And then as I follow that patient, I want to see that goes from high risk ideally to intermediate risk and ideally to low risk. Often it's not uncommon if you treat those patients assertively up front, you may actually just go from high risk to low. But I still want to see that trajectory of that is that patient goes from high risk to intermediate risk. If they're at intermediate risk still, does that mean I still have opportunity to continue to adjust their patient's medications? Yes. Maybe adjust their medication. Perhaps I need to be more aggressive with their diuresis as a time for them to go to pulmonary rehab. I really want us as APPs to think of it holistically, not just on what else do I need to do with the prescription? I also find it's a great time to engage the patients, right? Because you talk to the patients about this risk score and that their risk stratification is high, intermediate, or low. And they get very excited when you tell them that they're at that low risk category. And then they say, well, or I'm not there. What can I do to help? And sometimes it's just like, let's just get moving. Because even if we can improve your 6-minute walk distance just that much, it may be enough to help shift you to that lower risk category. Ultimately, what I'm looking at is intermediate is not good enough. If you look at the data, why the intermediate risk category has been split from just intermediate to intermediate high and intermediate low, is that that category was quite wide. And the patients in that category truly had a split between how many of them still had poor mortality rates compared to those people who were lower intermediate risk. So that again is another opportunity to intervene. And it very well may be that perhaps now you may add a fourth agent in PH, or you may continue to titrate up more aggressively again on that parenteral therapy. As don't forget, all patients are humans. So are they actually taking the medication? Because it doesn't work if you don't take it. And if they're not taking it, let's understand why. Is it cost? Is it side effects? Again, it's an opportunity for us to help understand them and guide them through that therapy. And ultimately, I want to see low risk. If we haven't got to low risk, we really need to understand why not. We may need to repeat catheterization as well to see what's going on, or if there's other comorbid conditions that may be contributing to their risk stratification.
I think that's the best definition of treat to low. It's you reassess every visit, and if they're not low, you keep going. What else can I intervene? What else can I modify? What else can I do with this patient to help get them to low? But the goal for all of our patients with PAH is to get them to low if possible, correct?
That's right.
Okay.
That is the goal. Now, I will tell you, we are very realistic in that we know some of our more senior citizen patients may sometimes kind of plateau out because they're unable to get that 6-minute walk distance over. But I want to at least see at minimum that they have significant improvement in their RV function as well, too. But we still want to drive that to low risk. So, I've seen some patients where they've done well for a really long time, and you just can't get them from that risk score of a 7 to a 6, right? So that number, if you're using the number, but just right at that cusp. And I have found that some of those patients, I'm just being really, transparent about it. It's often that, maybe they have some orthopedic limitation that just won't be able to drive that 6-minute walk distance to get over that hump. But the other things about them, their pro-BNPs are well controlled. They're compliant with their therapies. They're not hospitalized, and they're describing an active lifestyle and a functional class that supports that as well, too.
Yep. And I wish there was a better way to adjust 6-minute walk for other reasons, because we do have that. We'll have patients. And that's what's nice if you look at those calculators, is it tells you, if their heart rate is under this amount, that's a 0 score, or their systolic blood pressure is under this amount, that's a 0. So, you're adding it up. The higher the number, the higher the risk patient is as you use this calculator. So it's really nice to kind of see if your patient is scoring perfectly in all of those areas, except for 6-minute walk, and it's the body, not the breathing, that's keeping them from achieving that 6-minute walk. A lot of times we kind of say, well, your risk score is likely lower than what we're seeing because it's being skewed by the inability to walk, because you use a walker, because you have a bad hip or bad back, or whatever it might be. So that's something you have to kind of take into consideration. That's not very black and white about that tool.
Right. And then you do have to look at, the day of, when you talk about the heart rate needs to be, less than 96, the blood pressure greater than 110, right? Those are the things that give you those 0 scores. And sometimes you got to look at their overall trend. So what does this patient look like overall? Where they tend to be more hypotensive in general? Does the patient tend to be more tachycardic in general? So despite the fact that you have that, I still feel like you do have to add your clinical gestalt to your risk calculator, but really still use that risk calculator to drive your decision making. Don't rely on your gestalt so much that you miss an opportunity to intervene.
Correct. That is very true. Very true. All right, we're going to shift gears a little bit from risk calculation to talking about the concept of aggressive afterload reduction. So this is kind of showing up in literature. People are talking about aggressive afterload reduction. So could you talk us through a little bit about that, what that means to you?
Well, maybe I'm biased. My background is cardiology. We always did that. Some people get nervous about that. They're like, why are you diuresing these patients in their cardiac when their blood pressures are low? We're like, because that's what they need. You have to actually aggressively diurese that to reduce that that afterload so the patient's actually RV has the ability to function more appropriately. So to me, it's not new. We've always treated those patients that way. We've always been that much more assertive with that and not being ginger. It really has to talk about, you have to look at it from the perspective of the why, right? If their cardiac output is low, they're unable to generate that force that is needed to get through that afterload reduction. So if we can offload that right ventricle, the left ventricle is able to work more efficiently. You're able to get some improvement in the cardiac output. So it's just, I don't know, to me, it's not new. To me, I'm like, yes, let's do it.
Listen, we're a little slow in pulmonary, okay?
Don't say that. But, it's something that we've just been very comfortable with. And again, I think having that cardiac background, I think that we've long known much about pH is driven by the right ventricle, right? So as much as we get very focused on the right heart catheterization, and honestly, one of the debates when we talk about the risk calculators is there's not enough echocardiogram variables in the calculator. The only one that really mentions that is the Reveal calculator, and we're only talking about the presence or absence of a pericardial effusion. But you really don't see things like TAPSE or right ventricular strain or fracture area change, which are exceptionally important in understanding the function of the right ventricle in those calculators as well. So I do think it's important that we really do work on that so we can understand, we can do better with that ventricular coupling.
Mm-hmm. What do you think are some barriers that providers face when they're trying to get their patient to low risk? They're trying to reduce that afterload in these patients. What are the most common speed bumps people are going to run into?
I think it's one is just really feeling comfortable that your patients will tolerate those changes that you make, remembering they are fragile. But I think there's a lot of providers who maybe aren't as comfortable with the diuretic management. And sometimes you try to do that in a collaborative way. And maybe whoever you're trying to collaborate with may also feel somewhat uncomfortable. You say, hey, let me give this to the cardiologist or let me give this to the nephrologist. And sometimes I think if they're not that pH confident, right? I'm gonna put it that way. They're experts and wonderful at what they do, but just not that confident in that pH piece. I think that becomes one of the barriers. I think sometimes because their cardiac outputs are low, we see that lower systemic pressures that we get a little bit nervous about titrating those medications. But understanding that again, if they actually can get that medication on board, you will improve their cardiac output. So you will see an improvement in their systemic pressures. So I think it just kind of comes down to having as much experience and exposure as possible to making those adjustments. I think the barrier is just, in some sense, just us and us being comfortable with it.
Mm-hmm. So confidence and patient tolerance of therapies. Yeah, because a lot of times I'm like, you need this therapy, and the side effects are preventing them from escalating to a dose that they really need to or should be at. Because we're not seeing reduction in their risk score or something along those lines. So definitely having lots of conversations about side effect management, that there are things we can do to help manage your side effects. Because I had a patient who took his I think it was his ERA. He took it for like 3 days, had a headache and a stuffy nose, and stopped taking it. And then and I was like, call us. We could talk about that. We can talk about dosing. We could talk about all sorts of other things. But he unfortunately didn't get that.
And one of the things that we do really is we have that upfront conversation. You've probably heard in PH meetings that we call it expected events, right? There are things that we know are going to happen when you take this medication. So rather than look at it like it's a bad thing, it's part of what we understand the way the medication works. And so we expect that you may get some edema. We expect that you may get some nasal congestion with an ERA. We expect that you're going to get a headache with most of my PAH therapies, right, that we prescribe. And then really explain to them, like, how long do patients usually have to have that? And then what are the benefits to the other side, right? So pushing through that. And I really like to emphasize our partnership, that I will give you all the tools that I possibly can to help you through those expected events. Your job is to call and let me know what problems you have. But I also believe in being proactive. If I know you're going to get diarrhea, let me go ahead and tell you, go ahead and pick up that anti-diarrhea medication. If you're going to get nauseous, here's your prescription for your anti-nausea medicine. And here's what you're going to need for that headache, right? So I liken that to chemo. right? So when somebody has cancer, people don't go like, hey, I know you're going to throw up. I know you're going to get a headache. I know you're going to feel sick. Call me when it happens, right? No. Who's going to call? It's 2:00 in the morning on a Saturday, right? That's when those things happen. So I'm going to say, here are all the tools you need. So when it does happen, you have the tools you need, but let me know so we can partner together. Did it work? Did it not work? Sometimes I even do things like pain scales, right? So, some of these medications like sub-Q treprostinil can cause site pain. So here's your pain scale. When you're at a 3, take this. When you're at a 4, take that. When you're at a 9, do this. So again, it makes them feel in control because that's what a lot of patients feel like they don't have is control.
Yeah, especially with this disease. Absolutely. All right. Well, is there anything else that you would like to advise everyone who's listening here today of measures they could put in place to their practice to help get their patients to low risk?
I think one, you definitely have to have that team approach. So I think it's very common, and like you said, different style practices to determine when your patient should follow up. Some it's 3 months, some it's 2 months, some maybe 4 months. I'm going to tell you, I really believe these patients do better with more frequent touch points. So there's actually been some data that's even shown like patients as early as like 6 to 8 weeks, you'll see those changes in that risk assessment and that risk stratification. So really, I say, especially as APPs, let's lean into us, right? So rather than have someone call and someone, tell you what's going on and you relay that back to your nurse, your medical assistant, let's get those patients scheduled to see us, especially when we first start those therapies about every 6 weeks. And then alternate those visits with the physician. So I know we're all really busy, but these patients do take a lot of time. But if you're able to see them frequently, I find that the adherence to the therapy tends to truly be better. They also feel more confident in that partnership that the two of you are building. Share the risk stratification with them. So if you're using the reveal calculator, give them the number. Patients like the number. They like to hear it. I saw a lovely lady today who, when I met her, she was so sick. She was on ECMO. She's gotten so much better. And when I was transitioning her from parenteral to oral treprostinil, at each appointment, I will tell her, your risk score is this now. Your risk score is this. So she's been on oral treprostinil for quite some time, but she just recently had a heart catheterization, had all of her variables repeated. And I was able to say to her today, your risk score is 3. And she knew exactly what I meant. And her mom got so excited and started clapping because she's still at that low risk category. So share it with them. It motivates and excites them. It makes them feel like they are part of it. And then I would say, and don't be afraid to modify your therapy, right? I know sometimes we get concerned around the side effects or expected events. Let's start telling ourselves that like we're really great clinicians. As long as we follow closely with these patients, we can help support them through those things. And as we get more confident in that, the patient gets more confident, and then all of our patients would benefit from it as well too.
Excellent. As again, spreading great wisdom. That's why we keep having you back on the podcast and at the conferences too. So I'm so glad you joined us today to talk about all this and share your nearly 20 years of wisdom with us.
Oh, it was my pleasure. Thank you for having me here today. And as always, it's a pleasure.
All right. Well, if you want more of Melissa, you can find her on our podcasts. You can find her at our national conference. She's expected to come every year, whether she wants to or not. So you will likely see her there.
I signed in blood, I believe.
Yes. She's a wealth of knowledge, and we're so lucky to have her, especially from a pulm cardio perspective in managing these patients. So appreciate you so much. Thank you again for listening to the APOP podcast. Make sure you subscribe to the APOP podcast. It's a great way to support the organization. And then also, if you want some more content in and around pulmonary hypertension, we have opened a new site on our website. Our website is pulmapp.com, and we have a new page called Pulm Hub, and it has little bite-sized video learning opportunities for you. Also a PAPS digital learning app. You can also get information there. And you can always email us at info@pulmapp if you have any other questions. So thank you again for joining us, and we'll talk to you on the next podcast.